Hi, Dr. Ray here. I'm here to talk to you about some clinical correlations that are connected to development of the respiratory system. The first one that I want to talk to you about is called esophageal atresia. So atresia is a word that means an absence of an opening. And so there are lots of conditions that can occur where the title will have atresia in it. And so that's sort of something that you should hold on to. And one in every about 4,000 babies that are born has esophageal atresia. So essentially the esophagus doesn't develop properly and it's not connected to the different parts that does actually develop. So oftentimes there ends up being two parts, a superior aspect and an inferior aspect of the esophagus, but they're not connected to each other. And this condition very commonly is going to occur with another condition that's called tracheo-esophageal fistula, which we'll talk about in a second. And so, interestingly enough, it's actually somewhat difficult to make a concrete diagnosis on esophageal atresia because if it's not caught during ultrasound, it can be suspected during an ultrasound, and so parents can look for esophageal atresia or any problems with feeding or breathing after the baby is born. But if that doesn't happen, these babies are generally really fussy and they can't eat and they can't swallow any saliva. And so this is something that is an emergency situation because the baby can't actually get any nutrition. And so it does need to be diagnosed quickly. And I found this interesting paper that talked about how you can follow up an ultrasound with an MRI and get a more accurate diagnosis before birth so that you kind of can have an indication of what is happening in this particular patient before the baby is born. Although this is not something that's done often because of the fact that MRIs are hard to get and expensive. But I did find this to be interesting that it is much more accurate. And so generally on an ultrasound, you might see some sort of irregularity with the typical presentation of the stomach bubble that's supposed to be there. And then you can have just unexplained polyhydramnios because the baby is not swallowing amniotic fluid and excreting amniotic fluid like the baby should be doing naturally for kidney and lung and stomach function. And so you might just have polyhydramnios and not know why, and you didn't see anything upon ultrasound, but you could still sort of suspect that something might present after birth. Here you can see one of the antenatal MRI images, and this has pointing out with the yellow arrows the different parts of the esophagus that are not connected to each other, and oftentimes the inferior part of the superior aspect of the esophagus is dilated, and so it kind of looks like almost like a mass that's sitting there, and that's sort of a typical presentation upon imaging of esophageal atresia. And some of the symptoms that can occur, the baby could have some episodes of cyanosis. The baby might have foaming or fluids bubbling at the mouth because the baby can't swallow saliva. There's nowhere for the saliva to go down into the stomach. And coughing because you have fluid that might be entering the lungs instead of the stomach, and so the baby has a reflex to cough up the fluid. And here you can see on this radiograph sort of the blunt end of the esophagus here that you're seeing with contrast. And so oftentimes if the practitioners try to put a feeding tube into the stomach and you can't pass the feeding tube, they'll bring the baby right away for a radiograph to see whether or not the esophagus is indeed continuous or if there is atresia. And the biggest risk sort of immediately is aspiration pneumonia. And also starvation because the baby can't swallow any food. So surgery will have to be done very quickly after birth, hopefully within the first 24 hours. And so this condition goes along with another condition that's oftentimes called tracheo-esophageal fistula. So instead of having an abnormal connection, abnormal opening or continuity of an organ and as atresia has. The fistula is where you actually have an abnormal passageway between two hollow organs. And so what you are seeing in most of these is an abnormal connection between the esophagus and the trachea. And so these connections are not supposed to be there because they allow for air to go into the esophagus and they allow swallowed fluids to go into the airway. And certainly we want those things to be separated. And so there may or may not be a lumen, or there may or may not be a large lumen. And so every patient presentation is slightly different. And there is depicted here in this image another condition that's called esophageal stenosis, where you have narrowing of the esophagus. You may or may not also have a lumen in here. So this one here depicted is not actually a fistula, but these other ones, B, C, and D, all have fistulas, tracheo-esophageal fistulas. And I just want to point out that actually the most common presentation is type C, where the inferior part of the esophagus is connected to the trachea. And so this one is the one that happens most commonly. And then there's a special kind of tracheo-esophageal fistula that's called an H-type. And in this H-type, it's much more rare than the other types. But the esophagus is continuous, and so it goes down into the stomach. And the trachea is a relatively normal presentation, but there is an abnormal connection between the two. And so as you may imagine, a infant that presents with this condition may go a much longer time without any diagnosis, because they're still eating and they might just keep getting sort of lung infections and not really sure, you have maybe transient symptoms that come and go, not really sure what's happening. And so it's not until you do proper imaging where you can see that there is actually an H-type tracheo-esophageal fistula. And this is a radiograph that you can see the trachea come down and bifurcate into the primary bronchi. You can see some secondary bronchi here. And here you can see the esophagus is stenotic in the middle here, but you can still see some contrast throughout it, so it's still continuous. And here, right in this location, you can see that there is a connection between the two. So this is a H-type fistula. All right, the next kind of clinical correlation is called a posterolateral diaphragmatic herniation. And actually, this isn't the first time that we've introduced this to you. Dr. Brandt had diaphragmatic herniations in her movie in the last online module on body cavities and development of the diaphragm. So here you can see the normal presentation of the newborn with the thoracic organs, heart and lungs up in the thorax, and the diaphragm that separates the thorax from the abdomen and the abdominal organs down below. But when you have a congenital diaphragmatic hernia, some of the abdominal organs can come up and protrude into the thorax because you have an abnormal opening or a failure of closure of different parts of the diaphragm. And so here's a close-up view here, and as you can imagine, this is going to compress the lung and decrease functioning of the lung, and sometimes the heart as well. And so this can be a very serious situation that the newborn will be under and will have to undergo surgery, which can oftentimes be very successful to make the diaphragm opening decrease and make the abdominal organs go back down into the abdomen. You can also, have problems with loops of bowel that might be stuck up there, and then you can't pass any feces through the bowel, and that can cause an issue as well if it's more of a mild case. And so this is an exaggerated case here. You can see in this radiograph air from loops of bowel being in the thorax. When they open up the pleural cavity here, you can see abdominal organ loops of bowel up in the pleural cavity. And from this picture here, you can see the massive amount of compromised lung function that this individual had. And I wanted sort of to tie everything in together from what Dr. Brandt said in the last module with what we're talking about here with the diaphragmatic herniations, because she talked about two different kinds, the Morgagni and the Bach-Daleck herniations. And those are essentially sort of the same thing that we're talking about right now. It's just that they occur in different areas according to the different parts of the diaphragm that have not closed properly. So here, the Bactelec, you can see the ala or wing of the diaphragm hasn't closed properly. And so you would have problems with the pleuroperitoneal membrane, right? If you had problems with closure in that region. And then in the region of the Morgagni, which is just posterior to the sternum, you would have some problems with some of the body wall musculature not closing properly and causing this hernia. So I just wanted to sort of tie this in together with Dr. Brandt talking about the diaphragmatic hernia, and then coming here and talking about how it can lend itself to respiratory development because of the compromise of lung function that can occur. Okay, the next clinical correlation that I wanted to talk to you about is ectopic lungs. When I started researching this sort of general term, the ectopic lungs can mean two things. It can mean that you can have ectopic lung tissue in different parts of the body that it's not supposed to be normally, like in the neck, the chest, and the abdomen were the three most common places for it to be. But even more commonly than lung tissue being found in other places, you can actually find other kinds of tissue that can be in the lungs. One that was cited most oftenly was glial tissue. And I saw some other examples of like endometrial tissue. So some of these presentations would occur after birth. You know, later on in life, they can happen according to whether or not you have a sort of almost a metastasis where different tissue can break off and go to the lung. But really, what we're talking about for developmental clinical correlation is that developmentally you have lung tissue that might develop in other places. And so it's a lot less common, it's very rare, and if you do have other tissue that develops in the lung, that's usually surgically removed after birth. All right, the next condition, this is called a congenital lung cyst. Clinically, the term that you find most often is a congenital cystic edematoid malformation, or CCAM for short, or CPAM, which is congenital pulmonary airway malformation. And essentially what this is abnormal lung tissue that is formed in the lung. It's not functioning as lung tissue, but it is still growing and is oftentimes fluid filled so that it becomes a cyst. So it's a sac of abnormal lung tissue that's going to fill with fluid, and I did put the link in here. There's a whole society, and they do a lot of these surgeries for individuals to remove the cyst or lesion after the baby is born. And this is actually the most common type of fetal lung lesion. So if you have patients that have an ultrasound and they find a lung lesion, it most often is going to be a CCAM or CPAM. And so here you can see the abnormal lung here filled with air, and then here you can see the CPAM, and they can be solid. So I did find lots of lesions that were solid, which would be more in line with sort of saying that it was more like a tumor that could be benign. And so in this image here, you can see with the yellow arrow pointing out, and you can see the normal lung and then the fluid-filled sac here. Most are relatively small, and they don't actually compromise any heart functions. Lungs are not really needed until after the baby is born. And so the real risk here is that the heart is going to be compromised. And so if the cyst actually accumulates fluid quickly, they may have to go in and do surgery before the baby is born. And so really diagnosis by ultrasound is essential. They can also give the baby steroids if it's a solid-filled mass to prevent growth of the lesion, or if it's a fluid-filled cyst that is actually accumulating fluid very quickly and they're afraid that it's going to affect the heart, they can put a shunt in the cyst antenatally before the baby is born and have the shunt bring the fluid into the amniotic cavity, and that would stay there until birth. And then I found it really interesting when I was reading about this condition that you could do surgery before birth. You could do surgery during birth where they would prolong the birth process and have the baby still hooked up to the placenta and not complete birth until they had finished the surgery to remove the cysts in the lung, so that when the baby needed, you still would be receiving oxygen, and when the baby needed air, or remove the cyst, and that they would complete the birth process and the baby would be able to breathe without the pressure of having the lesion on the lung. Or they can, if it's small enough and it's not really compromising anything, they can wait till after the baby is born and then remove the cyst or mass. All right, and the next condition is called Respiratory Distress Syndrome. ARDS, or it's also called hyaline membrane disease, or it used to be called hyaline membrane disease because of the histologic appearance of the tissue. And I actually had this when I was born, because I was born premature. I was actually born in the year that they started giving babies as a experiment steroids to increase the maturation of the lungs. So essentially, if a baby is born newborn, then the lungs are not going to be as developed as they really should be and need to be able to have full functioning. And so this is going to cause a couple problems. One of the problems that is sort of the most typical presentation of things that people talk about is that there's a lack of surfactant. Because the type 2 pneumocytes are not developed fully, they haven't made enough surfactant, and this is going to increase pulmonary resistance, and it's going to make it extremely strenuous for the newborn to breathe. So imagine, if it's having that resistance super high, and every time you breathe it takes a lot of effort. That would be very tiring on a newborn to have to take in air. The other thing that occurs is that the epithelium isn't mature, and so it hasn't thinned out, and that's why they call it hyaline membrane disease. You'll see in the next slide there's sort of a pink hyaline appearance to the membrane because it isn't thin enough to be mature and have air crossing it easily. And so on these radiographs, you can see the normal lung here that is has a lot of air inside, and then the respiratory distress syndrome. One of the presentations or symptoms that you would see is a fluid accumulation in the lungs of a baby who has, is fighting this respiratory distress syndrome. And in this histological slide, you can see the sort of hyaline appearance, the thick pink appearance to the membrane, and the alveoli are collapsed. They're not open and filled with air as you would expect from a normal lung. So I just wanted to show you this to sort of integrate it together with what you'll be learning in histology through that section as well. And so if you don't have treatment for the baby very shortly after birth, then the baby is going to really have a decrease of oxygen delivery to the brain. The brain is the number one thing that needs to get the most oxygen right away, the brain, and then the heart. There's not a lot of physiologic reserve in those organs for decrease of oxygen. And so treatments would be surfactant replacement therapy. They may have to put the baby on a ventilator or give the baby positive airway pressure to support its breathing and make it easier for the baby to breathe. And essentially have time really help in the maturation of the lungs occur so that the baby can breathe without all that strenuous effort. And so there's a lot more success now than there used to be for treating respiratory distress syndrome. Okay, that's all I have for you. I hope this was helpful. If you have any questions, feel free to ask myself, Dr. Hill, or Dr. Brent. Have a good day.